Now let's welcome visiting professor Betty Irene Moore Fellowship for Nurse Leaders and Innovators at the University of California, Davis, Susan C. Reinhard.
I wish you could see this view. This is amazing. As I look across this room full of nurses, and I know there are others, but the nurses in particular, I feel so connected to each one of you because I know that all of us want to have the greatest possible impact in our careers. My path has been through policy, but I certainly did not begin in policy. Probably like most of the nurses in this room, I started in clinical practice. Then I went into education. Then I went into research, and then I found a path to policy by being a lobbyist, a nurse lobbyist, and eventually a high-ranking state health policy official in New Jersey. Before I went to AARP to lead the policy research there and the Center to Champion Nursing in America. And over those years, I've been really grateful to have been part of advancing countless laws, regulations, budgets to promote the well-being of individuals and their families. And that is how I've come to believe that nursing, whoops, I didn't know that was up there. It's back. Nursing, policy is nursing intervention at the societal level. I started with this idea, this vision, a long time ago when I was a community health nurse, but not quite that long ago. But this picture, this is in my office, has followed me throughout my career because it has always inspired me. But 6 months after graduating, I did become a visiting nurse in Essex County, New Jersey. I love that job. It really shaped my entire career in practice, education, policy, advocacy, and research, actually. What I did in the mornings was run a well baby clinic. I don't know if any of you have ever done that, but this is where you teach mothers how to keep their children healthy and safe. Now, I have a big sister, Joan, who is also a nurse, and she taught me, in 1974, by the way, that an 8-pound baby in a 25-mile-per-hour crash is flung forward with a force, an irresistible force, of 200 pounds. And nobody can hold on to a baby with 200 pounds of force. And that's when I first became really passionate about infant car safety. But before I knew it, we moved to Cincinnati. My husband, Tom, and our 2-year-old daughter, Laura. And I was midway between my master's degree, and I had to come up very quickly with an original thesis idea that I had to do in 15 months. So I was really, really stressed. I was in church one Sunday, which, by the way, was like the quietest place I could be with a 2-year-old. And it's like a voice from heaven, I guess, came and said, "Infant car safety." Bam. Of course, I had just been doing that all those years, teaching mothers after they had their babies to use a car seat. What if we could move upstream and have nurses in hospitals teach mothers to get a car seat, ideally before they go home, so that they can bring their baby home safely from the hospital? I know this is like, really? We're talking the 70s here. So I did construct a research project that was very, very simple. There were 3 groups, it was experimental. One group got this informational pamphlet, another group got this pamphlet, but also got a nurse counseling them on this, and the third got nothing at all. And I found that getting any information did make mothers more likely to use a car seat. But, good news, if you have a nurse coaching you, you're even more likely to get a car seat. So of course, I was thrilled with this. And my dean was so supportive. She said, "You gotta publish this." And I did. My first peer-reviewed publication. My husband, Tom, in the back, actually framed it. I still have it. But she did more than that. She paid my way to Chicago to a meeting of experts with the National Traffic Highway Safety Administration. It was like, wow. I was 28 years old. This was my first business trip, getting to do my research thing. But I get there, and that's where I found these experts said, nurses are part of the problem. What do you mean by that? They said, many nurses insist on putting the baby in the mother's arms, typically in the front seat, which we know is the most dangerous place you can put a baby. I was like shocked. And to tell you the truth, I was really embarrassed because I was the only nurse in the room. And I said, I gotta do something about this. Nurses should be leading this change, not resisting the change. And I also learned at that meeting that there was one state that had passed a mandate for infant car safety. And I said, you know what? When I get back to New Jersey, I'm gonna work on this. And I did. I went back to New Jersey, and that became my first foray into policy. I had been a member of New Jersey State Nurses Association, and I went to the executive director, and I said, do you think we can get NJSNA to support a mandate? She said, well, write a policy brief. I'll bring it before the board. I had never written a policy brief. I said, okay, I'll try. I knew the data, I knew research, and I was really passionate. So I did. I couldn't go to the meeting, but I was absolutely certain it would pass. Because once people know the facts based on research, they're gonna do the right thing. You know, I think it's called rational change theory or something. But that is not what happened. Instead, there was one board member who rode a motorcycle. And he said, you know, this mandate could lead to other mandates, and it will take away my freedom to ride my bike without a helmet. Yeah, really. And so I said, oh my gosh, they're not gonna support this thing? I gotta do more. So I started working with other nurses in NJSNA and outside of NJSNA, and I got some of them elected to the board of NJSNA. And I took some of them with me to my state senator to support a bill, and I offered to help write the bill, which of course I had never written a bill, but you gotta start somewhere. And I even did some public education at a zoo in his district, and I went to the Hospital Association to see if they would support this. And you know what? I got NJSNA to support it eventually, and it passed. In 1985, it took 4 years. It takes time and effort. So what did I learn in these early days of my career from this experience? I think of it now as ripples of influence that nurses can have to increase their impact. And the first one is at the individual level. That's where I started, trying to teach each mother to protect each baby, but we can have more influence than at the individual level. So my second ripple is research, nurses doing research. I don't have to tell the people in this room that research is important, right? But, and you know, it gives us the evidence for change, but research alone rarely changes practice and policy, rarely. It helps to publish, because we spread the evidence, we create an urgency for change, but we need other tools more than knowledge. And for me, guess what? It's policy. And you know what? This is part of our mission at the American Academy of Nursing. You can read this on the website. But we have to do more than that. That's what I learned. Got to do more. And I call this fourth ripple a mega ripple showing up. I should have gone to that board meeting, right? I didn't. Don't know if it would have mattered, but I think it does. Being visible and passionate really helps. And when you hit these different roadblocks, you need to find other ways around. You need to be tenacious. You need to find other people to work with, create a coalition, do what you have to do, and know it's going to take some time. So these are the lessons I have taken over the rest of my career to this day, and I'll share with you how it has affected my passion for family caregivers. Because I did learn that nurses can lead change, and we can really have big impacts, especially when we work together. So I'm taking you back to 1974. I did that well baby clinic in the morning In the afternoon, I was making home visits, and they were eye-openers. You know, you knock on the door. It's not the patient typically that answers the door. It's a family member, a neighbor, a friend. And my job was to teach those individuals how to help the patient by doing things that made me shake when I was a nursing student. So I'm teaching them how to give injections, how to do wound care, how to do tube feedings. This is the 70s, right? So we didn't know much about, very little research on family caregivers then. But now we do have research. And we know there are 48 million caregivers. And I know many of you in this room are very aware of this and are working in this area. The demand for family caregiving is growing. The population, of course, is aging. There's more complex care. There's more cognitive issues. There's more care moving into the home. So we have great expectations of family caregivers. But how much are we expecting them to do? And what do they have to say about it? By now, I'm at AARP, and I am leading the Public Policy Institute. And the Public Policy Institute is known as the think tank of AARP. But my vision was to make it a think and do tank, because I wanted AARP to do more about supporting family caregivers. I knew that I needed research to have a big policy impact. There wasn't much going on. In fact, there were no national data on what family caregivers are doing in this area of complex care. So I set off to find out what family caregivers are doing in this area, how did they learn how to do that, and what help do they wish they had, or were getting actually. 2012, I started it. Then I had an expansion of the study in 2019. We called it Home Alone. You can see Heather Young, one of my colleagues. She's not here right now, but she'll be here tomorrow. She was a principal, co-investigator with me, along with many other talented people. And what we found is that these family caregivers were doing the things I talked about, injections and what have you, but even things like peritoneal dialysis. A lot going on here. And half of the family caregivers are doing these things. And they said they were worried about making a mistake, and that they got little guidance from professionals. And they would say, we don't know what we don't know, so we don't even know what to ask. This is really stressful for family caregivers, and there are important differences based on race, ethnicity, age, and gender. We did publish it, and my AARP communications colleagues put out a press release, and they said, you know, we probably won't get much of a response because it's so clinical. Okay, I felt good about this study. And I'm sitting at my desk, and the phone rings. And it is a reporter from the New York Times. Like, this is a big deal. She was desperate to learn more about this study because, guess what? She was a family caregiver. She had been a family caregiver for 30 years, doing these kinds of things for her mother, who had multiple sclerosis. And then she asked me the question that still drives me today. So what are you going to do about this problem? Yes, Susan, what are you going to do about this problem? So I turned to policy. I had dinner with my advocacy colleague at AARP, and together, on napkins, literally, we wrote the tenets of what became a model bill called the CARE Act. It's a very simple bill. It says basically everyone who is admitted to a hospital has to be asked, do you have someone who's going to help you do these kinds of tasks when you get home? And if they say yes, would you like that person's name in your medical record? And if they say yes, then that caregiver has to be offered guidance. They may reject it, but they need to be offered guidance in how they're going to be doing this. We pushed this out across the state, across the country. Thousands of family caregivers showed up to support this bill. And we did. We passed it in Oklahoma first. New Jersey was actually the second, but we moved along. But I was yet still unaware initially that there were some nurses who did not support this bill in some states. Really? How could that be? They said, we don't need a mandate to teach family caregivers. And I agree, if only that were so. But we just had this research, And we had these family caregivers by the thousands telling us that wasn't true for all of them. So I had to go back into showing up, right? I met with the American Nurses Association state lobbyists. They had a meeting, and I asked if I could come to this meeting, talk to them, talk to nurses in those states. It wasn't every state, but in those states where there were concerns, listen to their concerns, see if we could adjust the legislation, not to destroy it, but to modify it in ways that made sense to them. And eventually it passed in 45 states and territories. We're still going. So here I am still showing up. You know, passing a law is one thing, implementing it is another. I am very committed to this. I'm the incoming chair of a very large health system in New Jersey. I'm working with our chief nursing officer in our system to implement this law and across the state and working with other states. Last year, I don't know where she is, but Karen Drinkard and I created the Volunteer Nurse Ambassador Program at AARP. These are high-ranking nurses, and several of them have stepped up and said, we want to join you in this effort of implementation. Some of them are in the room, and I'll probably see them later, but thank you for those in the room. And I know many of you are also doing work in family caregiving, so I thank you as well. It's all about scaling change through public policy and private sector policy. There we go. So policy is nursing intervention at the societal level. Some of us are looking for that impact. All of us are looking for that impact. At the American Academy of Nursing, we want the impact, and we are very passionate about our profession and our careers. Some of us are working at the individual level in practice, maybe working with families also. Some of us are engaged in research, perhaps education. And some of us are seeking that impact through policy and that mega ripple of showing up, which includes that huge administrative challenge of implementing policy. So I say, wherever we are, let's do it. Let's increase our impact. Absolutely. We can do it. So I thank you for listening to my story, and I look forward to hearing from yours. I'll be here the rest of the meeting. So thank you again.